Hi everybody. So now what we're going to do is go over gait. Hopefully everybody feels pretty confident with the posture stuff, and I think that gait again is really expensive, really important for understanding how people are moving and injuries and pathologies. Remember, these go together, but also include disease and what we need to do for evaluation. Okay, so let's rock and roll. Objectives, just making sure that we're understanding the gait and the pathologies and what normal is going to be really important, and then how we assess an individual, and there's an assignment associated with this that will hopefully help you guys drive some of this stuff home. Gait cycle, 2 initial contacts of the same foot, so stance and swing. When we are walking, the stance phase is 60%. So from heel contact to toe off, that's considered stance. And then the swing phase is from toe off all the way around till we put our foot down. Sorry. Terminology, step, successive, contact points on an opposite foot. So when we're like this, like toeing off on this guy and heeling down with this one, that's what we're talking about. So opposite feet. Stride is bringing this foot, so I step with this foot, bring it all the way around, and when I step again, so the step again is both feet, and a stride, so how far is my step, right? When you step, that's what we're talking about as a distance. A stride is if I step with my right, how long is it till I step with my right again? And then cadence is the number of steps per time, and typically we're talking about per minute, but it depends on the metric. Okay, so, sorry again, closed chain. Closed chain is when our foot is in contact with the ground. Open chain is when it's not. Stance phase is closed kinetic chain. Now, I will say that most people anyway, would consider walking to be a closed kinetic chain type of activity, because the rule is that when you are walking, one foot has to be in contact with the ground at all times. Gosh, I'm so sorry. Now, you also have one foot that is frequently off the ground, right? 40% of the time we have a foot that's in the air. So while there is an open kinetic chain part to it, a lot of people would consider, at least the stance part anyway, is closed kinetic chain, and then the swing phase is going to be open kinetic chain. I'll just make it simple like that, okay? You just need to know that. The functions of the foot are going to be supporting your body weight, obviously, acts as a shock absorber, especially with this windlass effect. So your plantar fascia is kind of like a ligament, but fascia is fascia. Hopefully everybody understands fascia. And it comes from the anterior part of your calcaneus and then runs all the way through to your first toe, your great toe. And it helps really like a springboard almost, as this great toe gets extended, right? So we're walking and it gets pushed back. What happens is, it builds up tension and then helps push you forward. So it helps springboard you forward. If your plantar fascia, if you have a problem with that, and or this joint, it really gets messed up. So this is so important in propulsion, in getting you to go forward primarily. And there's a video for you guys to watch that will help explain this a little bit more as well. Heel strike, that's your initial contact. This is where we really talk about the beginning of gait. So initial double support, remember I said you're toeing off on one and you're striking with your heel with the other. So this has to be like one foot always in contact. So as we're about to toe off, we're hitting with our heel. And that is the definition of walking. When we get into a flight phase, meaning both feet are off the ground, that's when we talk about moving into jogging and or running or sprinting or anything beyond that. Okay, so at this point, that particular leg, the heel strike leg, the knee is fully extended, meaning straight. The hip is flexed to 30 degrees. and the ankle is in neutral, meaning it's basically at 90 for dorsiflexion, okay? Quads, concentrically contracting. When we say concentrically, it means that they're shortening. Hamstrings are eccentrically contracting. Now, they aren't full bore, let's go kind of contracting, because, I'm so sorry, if they were, you wouldn't be able to extend your knee. And remember, eccentric contractions are when things are getting longer, but they're still contracting. So think about lowering a dumbbell down is the eccentric, and then bringing it back up is the concentric. Glutes, they're on the back side, so we're eccentrically contracting. Dorsiflexors, these are on the anterior part of your lower leg. Eccentric again. Now it seems weird that that's the case, but remember, we're not trying to keep our foot all the way up like that. They're kind of holding it in place. And then our calcaneus is going to act as a rocker, because as we hit it, we're going to rock right over the top. Okay, when our foot is flat, and it doesn't mean we're standing all the way over the top of it, we make our foot flat way before we're in medium stance. So 7 degrees plantar flex, because it's going to be pointing down. Hold on, let me get my dude. All right, this is one of my bony guys. So what we're talking about is when he's walking, so initially when we're doing heel strike, we're kind of like this, okay, right? And then what happens is our foot lowers down, so now we're in plantar flexion. Our knee is still flexed, and our hip is flexed. So we went from full knee extension and dorsiflexion to now we're in plantar flexion, and we have knee flexion now, okay? Everybody got this? This is the flat foot part. This is the loading response. We're not all the way down here. We're still out here. By the way, my hip was way more than 30 degrees. All right. So then we go to mid stance. So we are going to be somewhat dorsiflexed. Okay. We're not all the way in plantar flexion anymore. Our knee can be straight to 20 degrees, depending upon what's going on with us. And our hip can be flexed anywhere from 0 to 25 degrees. And notice we're starting to change what's going on with eccentric concentrics. And then glute med min are these dudes that are going to be on the lateral aspect. And remember, they're really big in helping with ABA deduction control. When they contract, we go out into abduction, so the leg comes out and goes in if they're not working. So we need them to work, so that way we're not dropping our opposite hip all of the time. Remember, we talked about the Trendelenburg kind of thing. For heel off terminal stance, so again, we're not talking toe all the way back here. What we're talking about is heel off. So notice 10 to 15 degrees of this guy. Let me get the other leg out of the way, because it's going to be confusing to you guys. So we get more dorsiflexion going on because our leg is starting to come back. Our knee is going to have to flex a little bit because our hip isn't fully extended. So we're at 0 to 5 degrees, or 10 degrees, sorry, of hip extension, a little bit of knee flexion, and then we're kind of sitting here. So this is our dude as we're doing this. And notice again, we're changing what's going on here. Then we get to toe off pre-swing, and now we're at 20 degrees plantar flexion because we're flexing our knee so much. Notice that's at 40 degrees and our hip is in extension, so we're kind of in this position, right? So we're really pointing that toe. Where are you guys at? Pointing that toe to push off. This MTP joint, that windlass effect, is really going to be in effect because it's going to be bent all the way back. Our knee is going to be bent. Our hip is back here, and we're just about to toe off. And then we go into the swing phase, where from the time that toe comes up off the ground to when it's going to come all the way up and around, and now we're going to be back in heel contact all the way up here. So what you're going to see is a lot of dorsiflexion. We're going to bring our foot up into dorsiflexion. We're going to flex our knee from 3 to 70, depending upon kind of what our activity is. You know, if people are like running and sprinting, they might really flex their knee. Or if they're just barely walking, they might not flex it nearly as much. And then the hip is going to flex all the way up to 20 degrees again to get us all the way back in this fully extended position, so that way we can hit our heel and go back into strike. So the initial swing back here, that's what they're talking about, is we're here, we're toeing off. Initial swing, we're starting to come just like this. Okay, we're starting to come forward with it. In mid swing, ankle goes back to neutral, the knee is flexed to 30, and the hip is flexed to 20 to 30. And then we get to that terminal swing, like I said, we're still in neutral. The knee is going to kick out into extension, just like we were before, and our hip is going to be flexed to 30. So now we're getting all the way back, and this is where we're at right before heel strike, right? So foot is dorsiflexed, knee is extended, hip is flexed, and then now all we have to do is just lower our foot down, and we are back in heel strike. Okay, a couple things to remember about walking versus running. Stance phase goes down to 40 and swing goes up to 60. And there's some variation to that a little bit, but I would say in general, it's just easier to remember that they flip-flop. The double support phase disappears. So there will be something called a flight phase, meaning neither foot is in contact with the ground, and sometimes only one foot is going to be in contact. Motion is the same. Range of motion is increased. You're going to have to flex everything a little bit more. You can't really extend it more, but you can flex everything a little bit more. The load through your joints and the bones and everything is going to go up 2 to 3 times, and the joint reaction is going to go up 6 to 8 times. Running puts way bigger load on your body than just walking does. When we talk about the normal parameters, and you guys should understand these, base width is 2 to 4 feet between your feet, meaning right to left, 2 to 4 feet. And that really depends upon how tall you are, how wide your hips are. Do you have genuvarum or valgum, which we'll talk about later. So the wider it is, people typically, not that they have worse balance because of that, but typically they have a wider stance because they have poor balance. So a wider base of support is going to give them better balance. Peripheral neuropathy, meaning they can't feel things very well, which is also probably leading to their poorer balance. Musculoskeletal problems, and genu valgum. Genu valgum is when your knee, so if you're just standing up normal, right? Old dudes, he's here, he's standing. We're talking about this knee, so this is the medial side in between the two legs. Genu valgum means that the outside part is compressed and the medial side is opened up. So he has what most people would consider to be called knock knees, okay? And then genuvarum is just the opposite, where the medial side is compressed and the outside part is opened up under tension, and those are people that we would consider to be bow-legged, okay? So they, if it's really narrow, if there's not a lot of space between the feet, it's because they have bow-legged legs, and if they have knock knees, they're going to have a wider stance between their feet. Step length is about 28 inches, so just over 2 feet. But again, it depends on your height, your leg length, because some people have really long torsos and short legs and vice versa. So often if people have really long legs, not always, but they're going to have a wider step length. They should be equal, but again, it's dependent upon a lot of stuff. And then stride length, remember, there's a difference. Step is from right to left foot. How far are those? Stride is from heel of my right all the way around to heel of my right. That is why it's a much longer distance, i.e. double. Okay. Lateral pelvic shift, meaning how much do your hips shift as you're going through these phases? 1 to 2 inches, so it's not crazy. And again, Trendelenburg's gait's already been covered. If you see this, you're going to see a much bigger shift. And again, the side that drops, that's not the messed up side. The stance side is the side that's the messed up side, because those abductors, the glute medius primarily and the glute minimus, aren't strong enough to keep you in a neutral stance. So that leg goes into adduction and your opposite hip drops. Lateral pelvic shift around 2, your center of gravity is kind of going crazy. Or sorry, vertical pelvic shift. I talked about lateral up there. Vertical pelvic shift around 2 inches, and if it's more than that, there's something crazy going on. But the idea is, when you're walking, your belly button shouldn't really be bouncing. Do I know people that have a very bouncy belly button? Yeah, they're typically like toe walkers or bouncers or stuff like that, but the idea isn't really for that to happen. You're putting a lot of extra stresses through your body, and it's much better to control what's happening. The high point is during your mid stance, because that's really when you're putting all of your weight and everything is straight. So that should be the highest point. And the lowest point is initial contact, because your legs are so far out, right? You're going to have one leg. If my initial contact is here and I'm touching my foot all the way out here, well, then my other foot is out here. So my feet are as far apart as they're going to get while I'm walking. So it makes sense that that would be the lowest point of my umbilicus when I'm doing that. And that's really about where your center of gravity is right around your umbilicus. Guys tend to be a little bit higher because they tend to have a heavier, wider upper body than females do. And then pelvic rotation around 8 degrees, because your hips are kind of going forward and back, and that's totally normal, because as you walk, they have to kind of be shifting and going, right? So your thorax is going to rotate the opposite way as your hips. And if you guys think about that, and when you're walking and stuff, kind of pay attention, and it should totally make sense. Center of gravity, like I said, about 2 inches anterior to the second sacral vertebrae, which again is right around your belly button, also known as your umbilicus. Cadence, walking 90 to 120 steps per minute or strides per minute. Running is 150 to 170. Honestly, ideal is 160 and above. Some people prefer even to get all the way up to 180. I can never reach that. I think the best I've ever gotten when I was running was like, I don't know, 165, 169. It's really hard for me to do that. I take longer strides. I get yelled at all the time that I should take shorter strides. It's just not in me to do it. Women usually take 6 to 9 steps more than men, unless you're like me and you walk like a dude. So then you take just the same number of steps as guys. You do decrease the step length and width, as well as the number of steps that you take per minute, because 1, your turnover goes slower, and 2, your stride length and width go down because you want to stay within your base of, or center of gravity within your base of support better. So you tend to decrease how far you're walking, and then you also decrease your speed because you're not as strong and balanced. Normal gait, weight transfer in a continuous manner from heel to toe. That's supposed to say toe for push off. Duh. That's basically how it happens. Heel, push off, toe. No sign of limp. Correct angle of toe orientation. Again, we're going to come all the way back into that full hyperextension for that windlass effect, and then to kick us forward. No evidence of excessive pronation or supination. Pronation is when that medial part of our foot is caving in, and supination is when we're walking on the outsides of our feet. Pronators tend to have genu valgum, so knock knees, and supinators tend to be our bow-legged or genu varum types of people. They have, neither one are really good. I'll just say that. You want to have a mid-foot stance, preferably not supinated or pronated. All right, and then when you look at people from right to left, going back to posture and everything else, this plays over into gait. Symmetrical, right to left in all motions, arms included. In the assessment, it is best to have a blank wall and have, so that way you can just really focus on the person. Is that always possible? Nope, it's not, but do your very best. Make sure that you can see the person without having things or people or whatever be between you and the person as they're walking. And it's best if you can be at least at hip level with your eyes, if not below that. So that way you're really just able to focus. If you're looking down on them, you can miss things, especially when you're looking at like the foot and the knees and stuff. It's really best to ask them to walk at a self-selected pace. If you ask them to walk faster or slower, it's probably going to change their gait, and not necessarily in a good way. Self-selected means what speed do you normally walk at, okay? And then I would always ask people to walk barefoot and in shoes, and preferably in the shoes that they typically wear. And I would look at their shoes. I would definitely do a shoe inspection, because the way that the shoes look, where their wear patterns and everything else, are going to give you a great idea as to what their gait pattern is. Pardon me. Before you even have them walk. Okay, observation. This stuff should really line up with what we've talked about with posture. So, anterior view, lateral tilt. What does it look like? Are they kind of standing crazy, sideways swaying of the trunk, horizontal pelvis sway, like all the things we just said that they should be this many inches and that kind of stuff, or in degrees as they're moving? That's the stuff we're looking at. Trunk and upper extremity rotate opposite to the pelvis. So think about when you're walking, if you're going to step with your left leg, you rotate, right? You're kind of going the opposite way. Your left leg swings in, your body swings to the opposite side. So as you're doing that kind of stuff, if people are stepping with their left leg and they're turning to the right because their leg is going to the right, that's just weird. That's not how it works. We always go opposite, right? And your arm, if my left leg is going forward, my right arm should go forward. We don't walk like toy soldiers with left arm, left leg going forward simultaneously. Lateral view, spinal posture, covered in the posture stuff. Lower extremity movements. We already talked about, the position of the hips and the knees and the ankles and the toes when we're walking. Are they doing what they're supposed to? Is their lumbar spine look good? Their C-spine, all that kind of stuff. And then the step length, stride, and then their cadence. Those are the things you see from the side. Posterior view. Same as the anterior, just on the posterior side, you're going to be able to see the heel strike maybe a little bit better, and the heel rise. Your base of support, how wide is it? Make sure we're looking at that still. Footwear, and again, like I said, creases, where's the wear pattern, and everything else. Compensatory gait, these are things that you guys are going to need to know and understand, and again, there's a video that goes over this stuff so you can actually see examples. But antalgic gait, what you need to know about this is that they are walking with a limp because of pain, okay? So it's not like they're just walking with a limp because they want to. It's because they have pain that is causing them to limp, okay? So self-protective, that's what it means. There's some kind of injury to the lower extremity, and it's changing how they walk. And typically what we see is a shorter stance phase, which then also changes their stride length and step length, because they can't weight bear on it for nearly as long. Arthrogenic gait means that they're walking really stiff and often a circumducted. So what they're doing is, instead of flexing their hip and knee and doing all the stuff with their ankle, they're swinging their leg out to the side because of whatever reason that you have to figure out, okay? Ataxic gait, gluteus maximus gait, gluteus medius gait. So ataxic, basically what's happening is they're walking with a wider gait. It's not very smooth, and they're doing it because either their coordination or their sensation is messed up. Usually we're talking about some kind of paresia or nerve damage going on that's causing this stuff to happen, and there's certain diseases that can cause that as well. Gluteus maximus gait, so that's gluteus maximus. It's your number one hip extender, most powerful hip extender. So if you have a glute weak gluteus maximus, sorry, I don't know why I'm struggling with those words, what you're going to see is your thorax thrust posteriorly, initial contact. So remember, initial contact, you're touching that heel down and you're going to lean back to kind of compensate, because you're not able to pull your leg back as well unless you do that. The leaning back is what's going to help you pull that leg back, because you're going to use compensatory muscles to make it happen. Gluteus medius gait is when you're going to have that lateral shift. So remember that Trendelenburg gait, same kind of thing. What you're seeing is, if my right side is messed up when I step with my right side and all my weight's on my right side, that right glute medius isn't strong enough to keep me with a neutral or straight hip. So that hip is going to drop into adduction, which means that my left hip is going to drop down, right? Okay. All right, hemiplegic gait. It doesn't mean that your entire leg is actually paralyzed, but what you're going to see is that they're not going to use it normally. And again, they're going to either circumduct it out to the side, or push it funny as they go through. And then Parkinsonian gait, lots of shuffling, very stiff arms. And when I mean shuffling, I mean like their feet are barely moving, usually head down, and they're just kind of doing this. Okay, so kind of shuffle, 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 and these people typically need like a cane or a walker or something to help with them. Quadriceps gait, it's what we see when people actually have quad injuries, forward flexion of the trunk and excessive plantar flexion because they can't control it otherwise. Short leg gait, they're going to be complaining of pain somewhere from their back down, which kind of cracks me if that's a definition. They're going to have a lateral shift of their hips to the involved side. So as they step, it's going to look kind of like a Trendelenburg gait. They're going to have limping, and then the flattened foot is going to be on the longer side. Now, often what we see, right? So the short leg is going to have like limping and lateral shift. So say our right side has a short leg, we're going to have that kind of Trendelenburg gait, and then a flattened foot. So basically we're going to go almost into a pronated position on the longer side. So on our left side, we would have that pronated or flatter foot, and then our right side is going to look Trendelenburg-like. What we would need to do is measure them. So go in and do the leg length discrepancy test to see what's going on. So measure from their umbilicus to their medial malleoli after having them clear their hips, and then from their right and left ASIS to their medial malleoli on the same side, and compare them again after clearing their hips to see if there's any discrepancies between their right and left side. And there's a couple other tests that they can do, and we'll go over those later when we talk about the really the hips, I think is when we talk most about it, but the SI pelvis in general, we'll just say that, and that way you guys will learn that kind of stuff in a little bit. Steppage or drop foot, these are usually caused by damage to our tibial nerve and or our fibular nerve. It depends upon what's happening with it and what we're doing, but in general, typically the injuries to a knee. I've had people fully dislocate their tibiofemoral joint, not good, tore a whole bunch of stuff. And then they're no longer able, as they're walking, because of that, to fully dorsiflex their foot. So as they're coming around, they can't do it. So they have, their foot just stays down in a plantar flex position all the time. So when they step and they're supposed to be hitting with their heel, they can't do that. So they hit and they slap their foot down because they can't actually dorsiflex and heel strike. Heel strike becomes non-existent anymore. And what they'll do sometimes is put a posterior splint, so plastic goes down the backside of their leg and then underneath their foot, so it holds them at least in a neutral position, so they can kind of get into this walking position that then allows them to come around. And then the plastic is usually such that it allows them still to go into that plantar flex position. So you can see that there is a difference in how they're walking, but at least they can walk without stepping or slapping their foot anymore. Finally, a couple of the last other impairments. So excessive pronation, I already talked about that. When you're walking, and usually we see these in people that have really bad genu valgum, which again is that knock-kneed thing. But what we're going to see is forefoot, rear foot varus, genu valgum, and internal rotation of the tibia. So they're really going to have this kind of like, I'm walking and I'm squishing all the way in, and my tibia is going to be internally rotated. Like excessive genu valgum is often related with this. We'll sometimes see people after lower extremity injuries, people that have obesity, fallen arches sometimes can come into this, but even still, like the excessive pronation isn't necessarily always related to fallen arches. Excessive supination, we see this in the really extreme bow-legged people, so forefoot valgus. We talk about the angling of the feet. External rotation of the tibia, meaning that the feet are going to be kind of pointed out instead of pointed in, like toes in pigeon-toed versus duck-footed. So we see the duck-footed more with the supination. And genuvarum, which is that bow-legged that I was talking about. Toe in, if their toes are just pointed in and there's no rotation of the tibia and it's coming from the femur, that's called anteversion, coming from the hips. So it would be coming from here, and actually the neck of the femur is rotated such that the whole femur is rotated anteriorly, which then translates down the leg and causes you to have a toed in position. If you are toed out and everything is completely lined up normal, that is called retroversion, because your hip, the neck, is actually rotated posteriorly, which then rotates the entire leg. All right, there's a couple videos that I posted of me walking. I want you to watch them because I think that they're going to help you guys see for your assignment what I'm talking about with changing your footwear, as well as looking at speed and how the speed of your gait can change how you're hitting your heels and toes or not hitting with your heels and toeing off and the knee angles and everything else. Now, when you're doing this, the one thing that I want to point out to you guys is try not to be overly critical and really understand that not everybody is going to walk the exact same. When you are doing a breakdown of how somebody's walking, you're looking for gross things. And by that, I mean like the big things. Don't try to be like, oh, it looks like there was 1 degree difference. No, that's not really a thing. You're looking for the bigger picture things where you're like, oh, that is definitely a difference from right to left. And I can see where this is leading to a problem. Don't be so nitpicky that you're picking things out that aren't actually there. I hope that makes sense. All right. Thanks.